Thanks, Laura, for the introduction. So my name is Olga van der Woude. On the call is also my colleague Neena, Seth, both consultant anaesthetists at the Evelina. So Neena has been involved in the development of the pediatric preoperative fasting guidelines since 2018. I joined her later in 2022 when we were going to move towards Sip Til Send, because I had some previous experience from working at a children's hospital in the Netherlands, where we implemented this in 2016. So yeah, let me tell you what I'm going to talk about today. First of all, I'm going to briefly discuss why people have to fast before surgery. So I'll go through the history of preoperative fasting and then also tell a little bit about the physiology. Then I will present the recent evidence for clear fluid fasting in children, mainly Sip Til Send. And I will mainly highlight the Swedish Sip Til Send study published in 2015, which basically started the whole Sip Til Send movement, and the recent Eurofast study published last year. And then at the end, I will tell you about our experience at the Evelina, how we got to Sip Til Send and what our current guideline is. Yeah, next slide, please. So why do people have to fast before surgery? If you can click again, please. Yeah. So basically, people became aware that people have to fast before surgery very soon after the invention of anesthesia. So anesthesia was invented around the 1840s. In the 1800s, people started experimenting with different substances. In the 1840s, they actually managed to provide good dosing to people so they would be anesthetized for a procedure. And ether was introduced in 1846, chloroform only 1 year later in 1847. And in that same year, the first doctor started to introduce fasting. And it was initially mainly to reduce the unpleasantness of vomiting, which a lot of people experienced around anesthesia. I guess the ether and the chloroform probably induced a lot more nausea and vomiting than all the anesthetics we use currently, and even they have a risk of nausea and vomiting. So yeah, it was to reduce the unpleasantness. But since the 1850s, they also started to become aware that the vomiting was not only unpleasant, but also potentially dangerous. And people developed aspiration pneumonias after having food particles aspirated to their lungs. Next slide, please. In the 1880s, there was a British surgeon called Joseph Lister who came up with like the first protocol. He said, no solid matter in the stomach and a cup of tea or beef tea 2 hours previously. And yeah, a lot of people in the UK started following this fasting guidance. And then in 1946, a study in obstetric patients was published. There were 66 cases of aspiration in 44,000 pregnant women, and this led to 2 deaths in obstetric anesthesia. Yeah, people started to be even more careful. He basically introduced the fasting from midnight, so no food and no drinks at all from midnight the day before surgery. And basically, people followed this until the 1990s, so a very long time. Because then people started to become more aware of the risks and unpleasantness of fasting for too long. In 1998, the ASA, the American Society of Anesthesiology, came up with the guideline that probably most people know best, the 6-4-2 rule, which meant people had to fast for 2 hours for clear fluids, 4 hours for breast milk, and 6 hours for light meals. And they also gave a recommendation for fatty meals that should be at least 8 hours, because that stays in the stomach a lot longer than light meals. Next slide, please. Then the last 10 years, there's been the movement towards Sip Til Send. And the first big study, I will come back to that a bit later, was published in 2015. 10,000 pediatric anesthetics were included in the study. And there were only 3 cases of aspiration. None of them needed ICU, and there were no deaths in the study. And after this, quite a few centers in Europe and also in the UK started to move towards a more liberal fasting protocol for fluids. So the APA-GBI had their consensus statement come out in 2018 to say, unless there's a clear contraindication, it is safe and recommended for all children able to take clear fluids to be allowed and encouraged to have them up to 1 hour before elective general anesthesia. So that's when a lot of centers changed from 2 hours to 1 hour. And like I said, from the 2016, 2020s, people started to move towards a more liberal protocol, started implementing Sip Til Send. Then just very briefly, a little bit on the physiology of aspirating. So there's 3 physiological factors that can increase the risk of aspiration. So one of the loss of protective airway reflexes, which is the case under general anesthesia. Because normally when people vomit, when they have their airway reflexes, they shouldn't aspirate under GA. That is lost. Then there's increased regurgitation. So, for example, people with gastroesophageal reflux or obstructions in their esophagus, like strictures, or a lower tone of the lower esophageal sphincter, which is also the case under general anesthetic. And an increased gastric volume also increases the risk. For example, with inadequate fasting or delayed gastric emptying. Next slide, please. So there's quite a few factors that have an effect on gastric emptying. So we know that gastric emptying is decreased when there's high caloric food in the stomach. Then people who use opioids have a reduced gastric emptying, and things like stress, pain, anxiety, trauma also reduce it, which is why trauma and emergency patients are generally not suitable for Sip Til Send. And some people with diabetes also suffer from delayed gastric emptying. And then there are also some factors increasing gastric emptying, like some drugs. But as you can see on the left, also liquid gastric contents actually help with the emptying of the stomach. Yeah, that's potentially a good thing to have some liquid in the stomach over having a completely empty stomach. What are the effects of prolonged preoperative fasting? People get irritable, they can become dehydrated, which can lead to hypotension on induction of anesthesia and difficult IV access. It can lead to hypoglycemia, especially in small children and children with metabolic disease. It can also lead, in extreme cases, to catabolic metabolism, leading to ketoacidosis, and children just become like very irritable and hangry, which can lead to a low patient and parent satisfaction. So it's all about getting the balance right. So balancing the risk of aspiration with the risks of prolonged fasting. What do we know about Sip Til Send? So I'm just going to discuss 2 fairly recent articles. So the first one is the one I mentioned before, the study that initiated the Sip Til Send movement. It was published in 2015 in Pediatric Anesthesia by 3 authors from the Uppsala University Hospital in Sweden. It was a single center retrospective study. So they studied cases between 2008 and 2013 who had been Sip Til Send and included a total of 10,000 elective pediatric anesthetics. And in that study, there were only 3 cases of confirmed aspiration, so 3 in 10,000. There were no intensive care admissions and no deaths. Then the more recent Eurofast study published last year. So as you can see, it was led by the same author that was also on the study in Sweden. This is a very big prospective cohort study carried out in 31 centers in 12 countries, and a total of just over 300,000 patients were included. And the aim was to compare 3 different clear fluid fasting regimens, which was Sip Til Send, 1 hour and 2 hours. And it was just depending on what the centers were doing already. Looks like the same slide, sorry. So this is a table with the outcomes of the patients. So I'll just go through the table very quickly. So you can see 4 centers did Sip Til Send, 23 had a 1 hour clear fluid fasting regimen, and 4 centers 2 hours. So you can see the majority of patients were in the 1 hour group, which was just over 250,000 of the patients. There were 34,000 in the Sip Til Send and nearly 22,000 in the 2 hour group. And the incidence of confirmed aspiration, that's the red box below. I've also written it out just below the table. And Sip Til Send, there were 1.18 aspirations per 10,000. The 1 hour group 0.96, and the 2 hour group 1.83 per 10,000. So as you can see, there's basically no difference. There were no deaths in any of the groups related to aspiration, and there was no difference in intensive care admission, which you can see just above death. So 1.2, 1.2, and 2.3 per 10,000. Next slide, please. So the conclusion of this study is that this provides evidence for the safety of reducing preoperative fasting time for clear fluids in children under 16 from more than 2 hours to less than 1 hour, which can mean 1 hour or Sip Til Send. Then I will tell you about our experience at the Evelina. So before we introduced Sip Til Send, Neena and one of the trainees carried out an audit, or actually multiple audits. The first one was in 2020, when the fasting guideline was still for 2 hours, 2 hours for clear fluids. And the average fasting time was 3.2 hours for, it was 3.2 hours at the time. In 2021, after the introduction of 1 hour clear fluid fasting, another audit was carried out, and as you can see, there wasn't really a difference. Patients were still fasting for an average of 3.1 hours. And it was ever so slightly better if they were suitable for Sip Til Send compared to not. If you can see in this table, you can see the median was 3.1. But this is all the cases, and as you can tell, that quite a significant number of children fasted for more than 10, and some even more than 15 hours for clear fluids. Yeah, that is why we became more and more interested in Sip Til Send just to to bring that number down. So in 2022, 2023, we carried out a pilot audit on Sip Til Send, which was in our dental department. So we included 94 patients. 38 were allowed fluids up to 1 hour before induction, and 56 were allowed Sip Til Send. And the average time between the last sip and induction was 105 minutes in the 1 hour group and 28 minutes in the Sip Til Send group. Also to say, there were no aspiration events in either of the groups. In 2023, we changed our preoperative fasting guideline from 1 hour for clear fluids to Sip Til Send. And this is for all patients with low risk of aspiration and elective surgery. And we kept the patients with high risk of aspiration or emergency surgery 2 hours for clear fluids. Breast milk, we changed from 4 to 3 hours at the time, and food and non-breast milk remained 6 hours. Next, please. So what is clear fluids? Clear fluid is fluids you can see through. You can read a newspaper through if you hold it behind it. So it's water, squash, diorite, clear apple juice, coffee or tea without milk, ice lollies, and also glucose polymers. So non-clear fluids are all fizzy drinks, pure fruit juice except for clear apple juice, fluids with milk, and fluids with thickener added. So for all the non-clear fluids, it's 6 hours. Then there's just one little warning on cordials and squash, because many of them are sugar-free and contain sweeteners like aspartame. And in July 2023, the International Agency for Research on Cancer released a statement that aspartame is possibly carcinogenic to humans. So we've actually been trying to get normal squash free of sweeteners for our departments, but I'm not sure how successful we've been in this. Then it's good to be aware that there's a difference between a light breakfast and not a light breakfast. So light breakfast is things like toast, brioche, biscuits, porridge, crackers, and Marmite. And it's best to avoid food that is high in fat content, like meat, eggs, and cheese. And things like Chinese takeaways, McDonald's and stuff is also all best to avoid, as that will stay in the stomach a lot longer. That's the foods that the ASA actually propagated the 8-hour fasting for instead of 6 hours. So that's also what's in our guideline. Then there are some conditions associated with a high risk of aspiration. So for these children, we still keep them on 2 hours fasting for fluids, which is children with reflux, renal failure with delayed gastric emptying, severe cerebral palsy with delayed gastric emptying, esophageal strictures, diabetes with gastroparesis, and there's some surgical contraindications like bowel obstruction, nausea, vomiting, or have to do something to the stomach. And this is all up to the consultant anaesthetist to decide if a child is of increased risk of aspiration. Then there's a group of children with diabetes and metabolic conditions. So our guideline is specifically not made for these people, but in our guideline is that they are supposed to be planned first on the list and they need to be referred to the metabolic team for a proper plan, because that's not covered by our fasting guideline. Then there are a few updates we've just recently made and are going to make very soon. So these are the updates that just came in place just a couple of months ago. And one of them is that we had to more clearly state that there's a different guidance for metabolic, diabetic, endocrine, and sickle cell patients. So they all get referred by the pre-assessment team to their teams to have a plan put up on our system. Then there's more emphasis on encouraging to drink allowed fluids. And also that they should preferably contain glucose or sugar to prevent hypoglycemia, especially in high risk groups. So that's the children under 2 years, under 2 kilos, or with metabolic or endocrine conditions. And we've also added a section with the treatment of hypoglycemia with the help of one of the metabolic pediatricians. And then there are 2 changes pending. One of them is the maximum allowed volume. So at the Evelina, we are using 10 mils per kilo per hour, maximum 100 mils. We've successfully implemented this after protocols from other centers in Europe, for example, in Sweden and in the Netherlands. And at the time our protocol, our guideline came out, there was no UK advice statement. But earlier this year, the CPOC, the Center for Perioperative Care, came out with the advice to maximize the volume for Sip Til Send to 3 mils per kilo per hour, maximum 170 mils per hour. And Neena recently contacted the APA GBI to ask what their advice is. They will come out with a statement soon, which will be 3 mils per kilo per hour, maximum 150 mils per hour. So we are now planning to align with the APA GBI advice, which we felt we had to do because it's the only UK wide advice statement, but it will make it a bit more difficult to implement, because now 100 mils per hour for everyone over 10 kilos is very easy, just half a cup. So we're just looking into the practicalities. And another thing we're going to change is the fasting time for formula milk in children under 1. And we're going to change that from 6 hours to 4 hours.